Good afternoon, everybody, and welcome to today's meeting of the West Yorkshire Health and Care Partnership Board. My name's Tim Swift. I'm a councillor in Calderdale and the chair of this board. I'm very pleased for you all to join us. The partnership is an important part of how we work together across West Yorkshire health, local government and voluntary sector to join up our services and support and invest in ways to meet the current and future health needs of people of West Yorkshire. Today's agenda includes an update from Rob Webster, our Chief Executive Lead, reports on progress against two of our big ambitions. The first one, our ambition to reduce stillbirths, neonatal deaths, brain injuries and maternity mortality, and the second, our ambition to strengthen the local economy. We also have, and very much linked to that second ambition, a paper on our response to the West Yorkshire Local Transport Plan and a paper on the West Yorkshire Equality, Diversity and Social Justice Strategy, which includes an update on the Dame Donna Kinnair review. I should perhaps mention that today is the first day of the Local Government Association annual conference in Harrogate. So we are missing a few council leaders because of that. The LGA conference was planned for 2nd to the 4th of July, but obviously postponed because of the general election, and hence we have the clash with the rearranged. At our last meeting in July, we noted that Tom Reardon had announced his plans to step down as the Chief Executive at Leeds City Council after 14 years. Since that meeting, we were very, very pleased to hear that Tom has been appointed as Department of Health and Social Care second permanent secretary, a job he commenced in September. Obviously, that's a hugely important connection for us, but also Tom leads a very strong legacy, and also we're pleased to welcome Mariana Pexton as the interim Chief Executive at Leeds whilst their permanent recruitment's taking place. And other changes, Andrew Gold, the chair of Airedale NHS Foundation Trust, stepped down at the end of September when his term of office finished. Andrew has provided valuable leadership over the last 8 years as a non-exec and then subsequently as chair, and also has been an important contributor to our partnership. Dr. Andy Withers, the deputy chair, has taken on the role of chair during the interim period until a permanent appointment is made, and Andy is with us today. I also want to highlight and say thank you to some people where there are future leadership changes. So since the last meeting, Dame Linda Pollard announced that she'll be stepping down as chair of Leeds Teaching Hospital Trust next year, as she comes to the end of her term and the maximum time allowed. And I think Leeds have just started the recruitment process. Excuse me. Sorry. Len Richards also announced his decision to retire as Chief Executive of the Mid Yorkshire Teaching Trust from early 2025. Carol McKenna announced her decision to retire from her role of Accountable Officer for the Kirklees Health and Care Partnership at the end of March 2025. Carol's worked for the NHS for almost 33 years, 25 of those in Kirklees. And finally, Anthony Keeley, the ICB's Director of Planning and Performance, has announced he'll be stepping down at the end of December, again after almost 36 years in NHS management. So I'd just like to record my thanks, and I'm sure the thanks of all of us, to those people for their contributions to this partnership, but more particularly, of course, to the wider NHS and service of the public of West Yorkshire. Finally, before I stop talking, it'd be really helpful just to remind people, I know we're all very used to these meetings, but please mute your microphones when you're not presenting or speaking. When you are speaking, please put your camera on and introduce yourself. And if people want to contribute at any point, if you use the raise hand function or the chat function between myself and the team supporting me, hopefully we won't miss anybody. So thank you very much. And item 2 is questions and deputations, which is an important part of our offer of giving people different ways of being transparent and accountable. However, we don't actually have any public questions today. Item 3 declarations of interest, which obviously are very important that we deal with these properly and correctly, which is why it's a standing item on the agenda, and remind people that all those in attendance and members should abide by the policies of the organisation you represent regarding interests. We do keep a composite register that brings together in one place all of the individual declarations from different organisations. But could I just gently remind people, if you have particular interest in any item on the agenda, to declare them when we get to those items. Thank you. And then item 4 is the minutes of the last meeting. So first of all, if I could just check these for accuracy, can I just ask anyone to indicate if there are any questions or queries about the accuracy of the minutes? I'm not seeing any hands or comments, so I'm going to take it that we are happy to approve those as a correct record, and then I'll ask Lauren to take us through an update on the actions.
Thank you, Councillor Swift. So there's 3 actions open on the action log, so just to give you a quick update on those. So the first one was around sort of engaging via the West Yorkshire Clinical and Professional Forum in respect of the antimicrobial resistance agenda. That's the Clinical and Professional Forum that's chaired by Dr. James Thomas. So Sarah Chadwick, who leads the work in the ICB, did attend the Clinical and Professional Forum back in September, and that was specifically to discuss the ICB's participation in a clinical trial to reduce antibiotic resistant UTIs in primary care. She's due to go back to the clinical forum in December to discuss metrics. There's also been a new national 5-year AMR action plan that's been published, and have a specific conversation about the blood culture pathway. Linked to this, and as a result of Sarah's attendance at the partnership board, I think back in March, she was also invited to both the Kirklees and the Wakefield Health Protection Boards to discuss the AMR agenda, which she's had those conversations, and then she's also due to do an AMR deep dive at both the Kirklees Clinical and Professional Forum and also the Kirklees Place Kitty over the next couple of months. I'm not quite clear on the dates of those, so it's in progress. Lots of positive steps since that discussion. In terms of the other 2 actions, I'm proposing both of those are closed. So we asked for a climate change and health paper to be brought to a future meeting. I've been speaking to Jen and Connolly, who's here today, and Frank Swinton, our climate change lead, and we've added that to the forward planner for the next meeting of the partnership board, which is on the 21st of January. And then finally, there was an ask around connecting our climate change work with the West Yorkshire Vision Zero work that's led by Mayor Tracy Brabin, who is here today, and the Deputy Mayor Alison Lowe. So Frank Swinton is now a member of the West Yorkshire Vision Zero board, and those connections have been made, so I'm proposing we close that one as well. And that was it, Councillor Swift. Thank you.
Thanks very much, Lauren. Just checking any questions or comments on those. Okay, thank you for those. We'll action those then. So item 5 is update from our lead chief executive, Rob. So I'll hand over to Rob and to introduce his report. Thank you.
Thanks, Councillor Swift. Hello, everybody. My name is Rob Webster. I'm the Chief Exec of NHS West Yorkshire and the lead Chief Executive for the partnership. And I always introduce myself in that way because it's important for us to recognise that there is a true partnership across West Yorkshire of councils, the NHS, the third sector and our communities, and that the representatives around this virtual table provide oversight and assurance about how that partnership's achieving its aims. And I'm really grateful for everybody who's in attendance today and everybody who's authored the papers that we've got in front of us, because I think they are relevant to our business and to the context in which we find ourselves. So I thank you to Ian Holmes for crafting this paper in my absence while I was on annual leave. It's a really helpful collation, I think was the word I was reaching for, of materials and some additional input. And it's substantial in nature. So I was just going to make a few points and then we can get into a bit of a conversation. So the first is that if we look at the big picture of having a new government that wants to set out a new mandate for health and care, there are some things which we should recognise as things that will guide all of our work. So the first is that the Secretary of State has come into office with a mandate that says, look, we need to see 3 shifts in the system: one from treatment to prevention, one from hospital to community, and one from analog to digital. And my interpretation of that for us would be that both of those, we need to see more emphasis on prevention, more emphasis on community, and more emphasis on digital. But we shouldn't lose the importance of treatment. We shouldn't lose the importance of hospitals, and we should definitely not lose the importance of analog and the importance of physical support and contact between individuals and human beings. That said, those 3 shifts are incredibly important and fit closely with what we're attempting to do here. And the Secretary of State has stated quite plainly that the NHS and to some extent the care system is broken and needs fixing. As part of his initial work, and as set out in the paper, he asked Professor Lord Aradazi to do a review into the current state of the NHS. And you can see the details of that report again covered in the text. What I think is important is that, Lord Darzi talks about the fact that the NHS is in a critical condition, but its vital signs are strong. So what we need to do is to work with the NHS and the health and care system to improve. As part of that, there are 2 things that he emphasises, which we would hold dear, I think, which fit very well with our economic and our service strategy. First, that we should really embrace new technology and the benefits that it could bring to the health and care system and to people and citizens. And the second is that we've got to invest in, care for, and do more with our own staff, because they are the ones who will deliver the improvements for us. So we've got the Secretary of State talking about big shifts and how we fix the system. We've got Lord Darzi of Denham talking to us about how broken the system is and that it's in a critical condition, but its vital signs are strong and we need to do those things. And then it's also worth reflecting that the Secretary of State also asked Dr. Penny Dash to do a review into the Care Quality Commission, which has just reported and states quite clearly that there have been significant failings in the Care Quality Commission, which means that it has lost credibility with the people it regulates. It has found it more difficult to find evidence of failings in services and therefore does not provide the right approach to assurance and improvement in the quality of care, and action needs to be taken. She also identifies that action's already been taken since her interim report, and we would all welcome, I think, the appointment of Sir Julian Hartley to be the new Chief Exec of the Care Quality Commission. Dr. Dash's review covers health and social care for colleagues sitting around the room. So we've got these things which state, some of the problems and what we do next. So I think that's the first thing we should recognise. We are in that context. And one of the things I would hope we would all reinforce is that's not a reflection of the work of our staff and our teams in delivering care every day. It is a reflection of the context that we're in and the improvement journey that we are on, that we all need to focus on. So the second big thing nationally is that it's all right having, as we always say, it's all right admiring the problem, but you have to solve it. You have to take action and make improvements. You will have noticed, hopefully, that yesterday was the formal launch of the 10-year plan into the NHS. So this is a process by which the Department of Health and Social Care is engaging with a wide variety of stakeholders to come up with a 10-year plan for the NHS by next spring. So there's an ambition for what does the system look like in 2034, which is going to make sure that the issues set out in Lord Darzi's report are addressed. And a range of national and local leaders will be brought together to help craft that, and there'll be substantial amounts of consultation and engagement with the public and partners. So that kicked off yesterday. So by next spring, we should see a 10-year plan for the health and care system, and you will have seen that the ADAS submission to the Chancellor had asked for a similar approach to be adopted across social care. So that's kind of the second part of where we are in the big context. We know what the problems are. We're processed to get to a future, but that's going to take time. And I think what we should recognise here today as a partnership is that there'll be a period between now and the publication of a 10-year plan and its implementation phase, which may stretch for a couple of years, which is going to be incredibly difficult. Because we find ourselves in a position where our financial pressures in local government and the NHS are substantial. That the operational realities that we face continue to be ones which are challenging. We should also recognise we're making substantial improvements in those against a recovery plan, and where expectations around improvement are going to be high. Rightly so, from the public and politicians and others. The budget on the 30th of October may or may not include some resources for the health care system, for local government and for others. We've yet to see that, have we? But whatever happens, I think what we're going to have to do is to make sure that we focus all of our efforts on improving outcomes for local people as a partnership. And one of the things that I'm really grateful for is that the partners in our places, our providers who collaborate together, the work with the third sector in our communities continues to hold fast in terms of that collaborative effort. And I'm really grateful that people do that in a time of financial distress. We clearly will be focused on making sure that we continue to recover health services after the pandemic, which we are making progress against the trajectories there, with a focus on shorter waiting times in hospitals, ambulance response times, good urgent care, good mental health provision, support for people with learning disabilities, and a focus on inequalities. We will be held to account for that quite firmly from NHS England and others. We'll also be focusing on our finances in the NHS and in local government, because we need to make sure that we are delivering value for money to the taxpayer. And we will also be focused on our 10 big ambitions as a partnership. In times of stress and pressure, we can sometimes feel that we have to default to a small number of things which are nationally directed. That's not the case for us, is it? And I can see from the agenda today, and I would encourage you to recognise that the papers demonstrate the work we're doing as a partnership, whether that's on people and employment, the economy, the work we're doing on maternal mortality, and so on. They're all about our 10 big ambitions, as well as those critical things that people expect around access to care, fast access to care, good value for money, etc. So as we sit here as a partnership, then I think we've done that baselining, we've got the future, we're in this period now where we have to stick together, I think would be my call to all of us, really. And I think we'll demonstrate that through the conversations we're about to have with the papers that are in front of us. The last thing I'd say is that I think we're really fortunate that we've worked really incredibly hard to make sure that we've got a strong partnership. And we're incredibly fortunate that we've got a good relationship with the Combined Authority and a fantastic Metro Mayor. And I don't know if Tracy wants to say anything about the government's approach to devolution, but I know that there's a strong desire for more power and authority to be invested in Metro Mayors and partnerships between combined authorities and ICSs.
Thank you so much, Rob, and thanks for inviting me to come in. It's always great to see you all, and I'm jealous of your tan, actually. I've got you a full screen and you look very freckly, and it's very annoying because it's freezing here. But I don't know everybody on this call, but hopefully over the next 4 years, we'll get to know each other as friends, because recently re-elected, 4 years, this relationship, this partnership, I really hope is going to give us better outcomes for the people of West Yorkshire. And health inequality is something we can not solve completely, but we can definitely be the tugboat that pushes that big tanker into the correct position. And as Rob said, there has been changes at the centre with the new Labour government, and the focus on devolution as the default setting. I think it was day 4, the Prime Minister invited all the mayors to go to number 10 around that cabinet table and say to us that we're going to empower you to deliver for your regions. That's moved on apace. And there is a Councils of Regions and Nations has had its first meeting. It met in Scotland. There's also a Council of Mayors with the Deputy Prime Minister, and there's going to be a Council of Local Authority Leaders, which I think is really important, particularly for those regions that don't have a mayor, that they also get their voice heard as well. There is the ambition that the whole of the UK will eventually have mayors. This genie is not going back in the bottle. There is definitely I think somebody somewhere has a map of the UK and they take it in turns where a mayor is now popped up, and they definitely want to fill that map with mayors. And I think it is a great way to grow the economy, because those with skin in the game, that know their communities, that can work like we do in partnership, surely that's how you get better bang for your buck. Also, the English devolution bill, we are working really hard with the centre to understand the framing of that. I said as a manifesto commitment, I would deliver a growth plan in the first 6 months coming back as mayor. All mayors are now tasked with that. And these growth plans will feed into the industrial strategy that will give the government the understanding of where they need to invest. We're going to absolutely influence government, having regular meetings with number 10 as mayors. There's 12 of us, 11 Labour mayors, 1 Conservative mayor, Ben Houston in the Tees Valley. But we have common endeavour, so we are very united to use our powers to deliver for the people of our regions. Just to say that we are also pushing on single funding settlements, so that's more freedoms and flexibilities over post-16 education, careers advice, employment support, transport, the house building as well. We know that, and as Rob often says, everybody needs someone to love, something to do, and somewhere to live. And I have really a great privilege that I can try and influence that somewhere to live part of the equation. Also, the collective focus as mayors is securing a devolution of health and work policy and funding. However, I'm not massively, leading the charge on that, because I do think our relationship in this partnership is probably what good looks like. So in some regions, Oliver Coppard is the chair of the ICB. I think Andy Burnham has just taken on that is part of their board, his responsibilities for health. So, changes are afoot, but I do think we have got a great partnership. Also, that 10-year health plan that Rob mentioned, I think it's great. We've got a minister who's really energetic and enthusiastic for change, and there's also his own lived experience, which you can't undervalue, of having just recently been on that cancer pathway and experienced the NHS really at the sharp end. So his experience is really, really good. And I think his approach to innovation is where we need to go, because as people get older, live longer, and have complex illnesses that need decades of managing, I do think that early intervention and prevention is very important. Very interesting, on a trade mission to America, we only came back last week, where the system's very different. the focus there was on treatment, of course, because it's profit motivation rather than prevention. Sure, we are in the space that surely prevention is the key. And I was very proud to bang the drum for West Yorkshire as the home of the NHS, where a lot of the innovation comes from. So I've offered to government and to partners, we are very happy to be that sandbox of innovation to trial things out as the sort of microcosm of the demographic of the UK. We are in a really great position to do that. So, you know, that specialism in health and digital, all of that tech is really just put us in a really strong position with government. So I am anticipating a lot of interest from the new Minister Wes Streeting in our region, and I'll be definitely making the case for this partnership, making us pretty unique in the country. So long may it continue. Thanks, folks.
Thank you very much, Tracy, and thank you, Rob, for your introduction. So, questions and comments. Yes, I've got Bev, Councillor Addy.
Hi, I'm Councillor Beverly Addy from Kirklees, new Cabinet Member for Health and Adult Social Care and Health and Wellbeing Board Chair. I'm really delighted to come into this and see things that I was really keen to get on board with, things that I wanted to bring that are already being done in many ways in Kirklees, but really wanted to push the integrated neighbourhood working. It'd be good if we could see more from the primary care sector to expand its learning around this and how we can work together with them, because they are embedded in the hubs, the hubs in the communities, and how we can do more. I mean, we do some, but we can do more, and really pick that up from the bottom up, which can help with that prevent. I know you go to the doctors for treatment, but there's a lot of preventative stuff can come out of that early intervention and linking more in with the community. Kirklees, we have got our wellbeing staff from the council embedded in health centres, and I'd like to see quite a lot more from the primary care on that. And love to hear Tracy mention the health tech, that we've got great stuff coming on in Kirklees with the National Health Innovation Campus and many health tech companies. So I'd really like to see us pushing forward with the primary care coming up more into that bottom end up.
Thank you, and welcome to your first meeting, Councillor Addy. Yeah. Rob, anything you?
Yeah, just to thank you, Councillor Addy. That's really well made point, and it's great to see the Innovation Campus buildings progressing so quickly in Huddersfield. On the integrated neighbourhood teams, one of the bits of political language I think that the Secretary of State uses is we need a neighbourhood health service, and I think that is pretty much what some of the integrated working in places like Kirklees, Leeds, Calderdale, Wakefield, Bradford starts to look like when it's at its best. So our priority around integrated neighbourhood teams really should develop and deliver that neighbourhood health service. And it's important to note two things, I think. Firstly, that the configuration of that will be different in different neighbourhoods because of the relationships and who's there. But that we can do some work collectively around what an effective blueprint looks like. And the Fuller Board, chaired by Carol McKenna, who's the accountable officer in Kirklees, is looking at that blueprint with support from Ian Holmes. So we should be able to describe that. And then secondly, we should also recognise that Tom Reardon's role at the department brings in that perspective at Whitehall level. You know, how do we join up departments so that they're supporting the wider determinants of health and integration, and also has an interest in that topic of that integrated neighbourhood health service. So I think we've got somebody who we know pretty well operating from Leeds part of the week, who's also interested in that space. So let's keep it on the agenda, and let's make sure as ambitious as possible, I think, about embedding that model everywhere in West Yorkshire.
Thanks very much, Rob. Catherine, just aware that your report was also from the ICB was also attached. I didn't know if there's any points you want to add at some point, but having said that, I've just seen Councillor Benner's hand go up, so I'll bring her in first. That's okay, and then come to you, Cathy. So yeah, Fiona.
Thank you, Chair. I'm Councillor Fiona Benner. I'm the Cabinet Member in Leeds for Equality, Health and Wellbeing. I'm really sorry I was late. My boiler's just broken, so I was just ringing British Gas. So I'm really sorry. Rob, can I just clarify, are these questions and comments on your report? Yeah, I just had a couple of points that I wanted to make, which may already have been covered as I've only just come in. I think one may well have been covered because I think it's a really obvious point, which is that I think both the Labour Manifesto and the Darcy report are really light on social care, and that we should put forward a request that, I think it's in one of the reports anyway, that we need a quick review, very similar to the Darcy review, not some great lengthy Royal Commission, but a quick review like this that goes to the heart of where the issues are. I think the other point that I wanted to raise was that I think when people talk about health, they kind of talk about health really meaning the health service. And actually, in the government's missions, if you kind of dig into them, there's 3 mission goals that sit under the mission. One's that there's an NHS which is there when people need it. So obviously that's health service stuff. But the second and third mission goals are fewer lives lost to the biggest killers, and fairer access type goal. And I think it's fairer Britain, but under as a health goal. And they're very much the kind of public health. That's public health, isn't it, rather than the health service. And I think it's really important that we keep highlighting the importance of that public health work and that fewer lives lost to the biggest killers. I mean, that's about smoking and obesity, obviously, and it's not even only a health response that's needed for that. If you want to get rid of advertising of high salt, high sugar food, you have to also involve planning and licensing, for example. So I think when we're talking about health, we need to ensure we are talking about that kind of partnership working that's wider than just the health service, and in order to meet those mission goals that are much wider than only people being able to access the NHS when they need it, important though it is. I do think Tom's appointment's really great in that I think the fact they've appointed someone from a local authority background and actively supported him to work in Leeds 2 days a week, I think is really symbolic. I think it signifies a wish to work with local government and to devolve stuff out of London. So I think it's a real opportunity for us in our region. Thank you.
Thanks, Fiona. Let me come to Cathy next and then Marie. Yeah.
Thank you, Tim. So what you have appended to Rob's report is my NHS West Yorkshire ICB chair report for our last quarterly board meeting in September. There's a few things I wanted to highlight. One, that we are having a focus on series for 24-25 on our role as a commissioner and in our role as a convener of our partnership on how we reduce health inequalities. And public health colleagues from across the system have worked with us on this, and in a moment, or by the magic of Lauren Phillips, that report will come into the chat box, and it's also available in my report. We hope this is helpful to you all, particularly to Health and Wellbeing Board chairs and to Place Committee chairs in taking that information. And our public health colleagues have identified 4 priorities for our system. One is for children and young people, particularly their mental health, and tackling asthma symptoms and issues, as well as the prevention agenda on asthma-friendly schools. We looked in the summer at long-term conditions, and we'll make that document available soon. Our next topic for December will be looking at frailty, and then into the new year we'll be looking at maternity services, which will complement the report that you've received today. So they're helpful for us as the Commissioner, but hopefully they're helpful to you through your partnerships as well. And one really clear recommendation is around having more asthma-friendly schools, for example. The other thing I wanted to highlight with you is that the NHS West Yorkshire have been developing, and we've submitted to NHS England, our infrastructure plan, which has been led by our colleague Jonathan Webb, our ICB Director of Finance. But I'm really pleased in discussing this with Tracy and colleagues within the Combined Authority that there is an opportunity to align our infrastructure plans to make sure we're complementing what the Combined Authority is aiming to do in terms of growth plans, but also from our point of view within the NHS, trying to work on mitigating risks. Our concern, and it was in the Darcy report, that the NHS estate in general across the whole of the country is not in a good state, and particularly in the north of England and particularly in West Yorkshire, parts of our NHS estate are really not fit for purpose in different ways, because we want to have modern facilities for our local residents. We're really pleased that Airedale NHS Trust, Foundation Trust, has its RAC capital funding protected with the new government, and we know there's a review taking place on other opportunities. And if you haven't been to Huddersfield Royal Infirmary A&E recently, get along there because it is lovely, but it has taken over a decade to make that happen. So one of the concerns and the risks is that the NHS estate is not quite keeping up with current housing plans. And I know Tracy and colleagues at the Combined Authority under the new government are being asked to look at new housing trajectories. So it's something we're working on together. And I think it's a really good example of our partnership. The last thing I wanted to say, which is linked to Rob's and my report, is the review of the Darcy report. And there is a recommendation from our colleague Hayden, who put that together with colleagues around creating a compendium of good practice in our partnership, so that we are ready and able, that as the new government come to us for examples of best practice and the ways in which Rob and Tracy have talked about these opportunities and forums that are coming together, that we have ready best practice, whether that's in our place partnerships, our provider collaboratives, and the ways in which we work across sectors in health and care. So it's an invitation for people to show off their good practice that we can then bring forward. So Tim, thank you for that. I just wanted to particularly profile those points.
Thank you so much, Kathy. Marie, I'll come to you next.
Yeah, thank you, Chair. Mainly, I've never met you before, Tracy, so thank you for that, your introduction, etc. I sit here basically sat in West Yorkshire, and I've now worked in it for many years, and I have to say I'm quite proud to be in West Yorkshire and quite relieved, if I'm being honest, because I think there's people on the call that can make things happen. And I do believe with yourself, Rob, on the plan, and Tracy in that mayor's position, if we can't do it, nobody can. And I genuinely believe that. I think I said it on our chairs meeting this morning, and apologies for those chairs on the call as well. I do think we do need to be brave. What I guess it's a plea, really, as much as anything. I am getting a bit fed up with being told how bad we are, and it feels I'm a bit in despair, if I'm being honest with you. It would be lovely for West Yorkshire to come out with terminology of hope and a clear vision of what a modern health and social care system looks like, so as the general public knows what we're working towards. And I do really think we need to lay that vision out and that kind of picture for people to be able to see, because at the moment it feels like we're all sat in the smog and it's all despair and it's all money. We know it's tight, but I think we do need to actually show that picture. We need to describe it. And the other thing is a plea really to yourselves in these positions, and obviously I'm very happy in my own trust to support the whole thing. I do think we've got to stop with initiative-itis. We've got initiatives coming out of every area of the health and social care system. It would be really good for West Yorkshire to be known for something that is outstanding. And if that is neighbourhoods and that is integrated care, then we need to be brave in describing that, and we need to do it. And it's a real plea, my trust will do it. I think a lot of us on the call in chairs, I'm sure they would do the same. We need to park our jobs, our own position, and describe that future and work together. So I just want to give it a vision of hope, really. And as I say, if we can't do it with people like Rob and yourself, Tracy, and the rest of us on this call, then we want to be shot, because I think we've got an ideal opportunity. Thank you.
Thanks very much, Marie. That message of hope, but also lays down a big challenge to us. But that's probably a good point. Are there any more comments or summing up on Rob's report? Rob,
I just
add
a couple of reflections, really. I think, the first is, really grateful for the reminders that we always need to be explicit in our support for social care and local government and the wider determinants. I think you can see from the agenda that it's part of our the way we do things around here. But if you don't say it, people might not hear it. So ADAS have called for a 10-year plan on social care, and that to be done incredibly quickly. There is a national social care workforce strategy that's been published that we could adopt. There's lots of things we could do, and one of the things that we should all welcome is that Robin Tuddenham, the Chief Exec of Caldale Council, has just been elected as the President of the Society of Local Authority Chief Executives. So again, we've got a very strong national voice that we can draw on, who is informed by the work we do here. So thank you for that. I think the points that Councillor Venner made in terms of fair access and fewer lives lost, again, we're a true partnership here. It's an integrated care partnership that looks at those broader issues. Some of the work of national government will be important here around obesity, alcohol, etc. But some of it is for us to do. And what I would say, Councillor Venner, is that there's a spectrum of interventions on the big killers. And if you look at the 10 big ambitions, they include some of the wider work that we need to do, but they also include some of the interventions that we can make on cancer, for example. So if we had earlier presentation on cancer, fewer lives would be lost. But we have late presentation on cancer. We're making improvements, but there's further to go. So definitely all in for prevention and secondary prevention and tertiary prevention. And the good news, to Marie's point, is that Sarah Smith, who was sitting next door, our consultant in public health, and her colleagues have come up with a fantastic evidence-based tool which describes the interventions that will make that difference to those populations, because we know what we can do and we need to get it done. And I think your call for a bit of hope, Marie, is a really good one. And Claire Smith, the coup from Leeds, is also on the call, and her support for that, tempered by realism, I think is exactly right. We have to hit the right tone in terms of we're realistic about the challenges and hopeful for the future. Thanks.
Thank you. Khalid?
Thanks, Tim. Thanks, Rob. I'll just introduce myself. Some of the people on the meeting may not know me. I'm Dr. Khalid Naeem. I'm a GP in Batley and Dewsbury. And I've been working in the CCG for a long time, and I've been chair for the Kirklees CCG till 2022, when it turned into an ICB, and I'm now the plant care and urgent care lead for Kirklees on the Mid Yorkshire footprint, and I'm also the chair for Clinical Prevention Forum for Kirklees, and I also attend West Yorkshire meetings, Clinical Care Professional Forum, and our meeting here. And I just wanted to say that the partnerships we are developing, I think this is a wonderful opportunity for us to see how wider our partnerships go. We need to look at healthcare staff retention, recruitment and retention. We need to see how we can make sure that West Yorkshire is the best place to work and live. And how we can promote that. We need to also look at health inequalities, where we are seeing some of the realizing some of the deprived parts of our communities are having their their local sports centers and their local sports facilities being shut down. And patients are coming in where they were using these facilities, and now they can't. Their children now have to travel longer to go and avail some of those facilities. And I think this is something which we need to look at as on a partnership level. We need to also look at how we can partner with our schools and universities to grow our future workforce, local workforce, who has got a lot higher chance of staying and working in the area than getting people from elsewhere. In my opinion, we need to start partnering with them. We've got a wonderful opportunity in Bradford University and Huddersfield University, their Health and Wellbeing Academy, and I think we need to engage our schools into it. We need to have better presence on their open evenings and career affairs. And I think we've got a lot of opportunities. We just need to avail some of those opportunities. We've got a very keen younger generation who want to serve the community and work in different capacities in hospitals, in communities, and we need to develop those partnerships for future. And I think we are very well placed, and we need to have more open mind for these opportunities. Thank you.
Thank you. Kim? We can't hear you at the moment, although you're not showing as muted. Okay, sorry, so lost Kim for a moment. Rob, any final thoughts, or shall we move on to the next item?
Let's move on to the next item. I think some of the things that Khalid talked about in terms of schools, some very good practice locally, and that's one of the issues in the people strategy for West Yorkshire that we should really start to exploit further.
Thank you. Agreed. So thank you very much, everyone. So moving on to item 6, which is our patient and public voice section. And in a moment, Lauren's going to start showing the video that covers this item, which is then directly linked to agenda item 7. So rather than have any particular discussion on this, we'll then go straight into item 7. So Lauren, I'll let you deal with the tech.
Thanks, Councillor Swift. Just give me one moment and I'll share it on the screen.
My name's Sasha and I've got 3 children. I had them all here in Leeds and I felt really empowered after all of my births. But what would make me feel unsafe is if I felt intimidated or I wasn't able to speak up. That would definitely make me feel more vulnerable. I totally agree.
I think whatever route you kind of go down, it's just making sure the people around kind of trust and really listen to what you're saying.
Everyone's pregnancies are different, aren't they? And everyone's birth experience can be different as well. You don't know what you're going to get.
Feeling supported, listened to, valued, I think that's vital to sort of any care that you're receiving. I think what's really important is to be like an active participant in the whole process, because so many people, and particularly when it's like trauma, it's about feeling like birth happened to you, everything happened to you, like you weren't there. And I mean, my birth, I wanted a home birth. My little girl went 17 days over. So it ended up having like an emergency C-section. So in terms of what I wanted, it was completely different, but I'd done my preferences, I'd been quite detailed, and I was supported actually by the midwives. You know, everything that they had to do, I knew why they were doing it. And I knew that I could say no, but I knew that actually it was for both of us, it was the best.
I am mixed race. My dad is for the Caribbean, Jamaican, and my mum is English. My dad came over with his mum around the Windrush time and came over on one of the Windrush boats. So grew up in a very traditional Caribbean household, very strict with the girls. So we've definitely got a mixture of ethnicities within the family. When you give birth and they come and test your child for like sickle cell and stuff, I did have a conversation with a young lady that was about family coming from back home, and I was like, my family's all here, they came at Windrush, and I said, I don't understand what you mean, but it's like she wasn't listening.
Getting to know your audience, getting to know your patients will naturally make them feel so much more safe.
Yeah, Leeds is, you know, a huge multicultural melting pot, which is beautiful, and with that comes the responsibility of organisations like the NHS to understand the different cultures.
From a perspective of the people that give the care, I always think if people can not just think, okay, this is a person who, you know, maybe is Muslim. So I've had experience with a Muslim female before, and just to use that as the blueprint. That Muslim person is still an individual. So having a personalised experience, not just the same template as previous. I don't think anybody necessarily comes to work to go, I'm going to really make that black woman have a really horrible experience today. When people are tired, when people are stretched, naturally you kind of go in an autopilot, and if autopilot is your echo chamber of whiteness, difference becomes an issue, it becomes an obstacle, becomes a barrier. It might be a case of that culture's quite loud, so when she says she's a 10 and she's screaming, she might not really be a 10 and screaming compared to this white person who's a 10 and she's pink. Well, no matter how painful something is to me, I can't go pink, so there's no direct comparison.
In my 4 years of experience, I didn't see a diversity within maternity care, and I understand some people will go for it, some people won't, but you can hire people that can reflect different diverse backgrounds, and that can help give some people ease. Personally, I came from a very mixed background. I grew up in a country where I was introduced to loads of people, different backgrounds, but some people don't get that, and they're used to seeing a certain kind of person in front of them. Having this diversity within the ward and the service can help.
It's also about representation amongst the staff that have the understanding already of different various cultures. I mean, there's so many within Leeds, isn't there?
So diverse.
Yeah, but as much as you can, and obviously they have to be trained to the same standard, but it just really makes that massive difference. Some cultures prefer to have women there, don't they, rather than men, and just bearing all these different things in mind and not kind of making assumptions.
Individuals don't need to be white, male and middle class to succeed or lead a team. People with accents can lead a team. Seeing those different diverse people in senior positions so they can change cultures and change mindsets from the top. I think that's a real, point of improvement, shall we say, where the NHS could do a little bit better.
You can have mental health issues from the very beginning, like from the moment you conceive, you can have these problems. Exactly. And I don't think it's talked about enough. I know that sometimes it just takes an extra 5 minutes of saying, are you really okay? My daughter went to hospital because she was dehydrated, because she wasn't getting enough breast milk. I didn't know that, first time mom. I was giving her bottles, but I was also trying to breastfeed. Consultant came in and just snapped at me. That's not good. It's just understanding where the mum is, as well as the medical stuff that has to be done for the child and the mum. I get it, but also understanding mum and her mental state at the time.
My first was emergency C-section at 33 weeks. Being in theatre, absolutely brilliant. Couldn't have faulted it at all. They were just making you comfortable. They made sure you were okay. They made sure your baby was okay, but unfortunately for me, I couldn't have him straight on my chest because he was premature by 7 weeks. With my daughter,
how long did you spend in hospital with your daughter?
6 days. I was a lot more confident in myself going through birth and labour and knowing what I needed to ask and what I didn't need to ask.
I am originally from Malaysia. I am an asylum seeker in this country. You know, for migrant people, the problem that they're scared. We have fear, we have hesitation to trust. Back in my country, when you work with the healthcare, it's just like you don't have a right to ask, you don't have a right to know what we're going to do with you, you just have to go with us. But here, I found everybody is friendly. It's nice to feel like you'll be treated like a human.
Because we are in Leeds, we are lucky to have Hamla midwife who are very aware about migrant people. The personalized care in maternity should be worldwide spread all over. Yes. We are foreigner in this country. We don't have anyone, so we don't have relative, our mom who used to take care of us. So this midwife can so-called as a mom as well.
Hamla team is like a specialist team. If there's a possibility that they could give a workshop to everyone else, because sometimes we might be angry and blame them, but then they are not trained on that specialty.
I was actually consultant-led from the beginning. I only met a community midwife once, and until I met the consultant, I feel like it was quite a negative experience because it was a different person every time. And then once I met the consultant, he actually listened. Meeting the consultant, I was definitely nervous, especially with it being a male and me having long-term health conditions. I knew it was going to be a difficult pregnancy and childbirth anyway. So it was nice to walk into the room and everything was at ease and it wasn't a rush. My partner actually said to me he's never spent that long sitting with a doctor. Your opinion mattered, it didn't just get brushed off. And it did change you from being nervous every appointment to understanding why they're doing everything they're doing to you and they're prodding and poking you all day long.
I think I had the most brilliant midwife ever, I could ever ask for. I wish she could be my best friend. She was lovely, you know. Whenever I knew that maybe next week she's coming, I always looked forward for it. She was like, you know, when you are happy that your mom is coming, if your mom had gone away, it was the same feeling that,
That
feeling.
Same feeling. Did you have the same midwife throughout your pregnancy?
Yes.
That's amazing.
Yes. She used to understand that, okay, I'm an asylum seeker. There are things that sometimes I'll open up to her. She will understand. She will refer me to here and here and here. When I had problems with my accommodation, she will sort out. She will just pick up the phone, find time. I think her kindness kept me sane.
Leeds is beautiful in terms of the depth of cultures and the depth of different people.
I love it. I love to see different cultures and I just think it's always seen as a heated subject rather than just enjoying what it is.
My mum, she's actually Ghanaian, so we had loads of conversations as to her maternity experience. From my perspective, just knowing like some of the things that she went through compared to mine, had real personalised care. I think like, you know, I had a really lovely experience.
Feeling safe is so important, and for me that was about having a voice and feeling like I had those choices. I'd had lots of discussions with lots of different professionals and felt that I was supported and that I was offered support throughout the whole journey, you know, from finding out when I was pregnant right through to the very end. It's never going to be a one-size-fits-all, is it? And I think just giving people those choices to make sure that everybody gets a really personalised experience. We're all unique.
My mentor always said, one, kindness don't have language, kindness don't have colours, kindness don't have country.
Thank you. We just pass our thanks back to those who've produced that. I've got to ask Debbie Gibson to introduce the next item, which is on our ambition around reducing stillbirths, neonatal deaths, brain injury, and particularly maternal mortality. Debbie.
Hi, good afternoon. Thank you. So I'm Debbie Gibson, I'm the Director of Midwifery for the West Yorkshire and Harrogate Local Maternity and Neonatal System. Obviously, I'm going to talk about my paper, but I just feel I just need to say a moment about that video. I have seen it a few times already myself. Every time I find it so moving, and I just think some of the bits summed up at the end. You know, kindness doesn't have language, kindness doesn't have colour, kindness doesn't have country. I think those things just to be said out loud, just so important. It's about everything we do in maternity care. And about it's, you know, all about if we really listen to women and truly personalise care, we can really make a difference and make them feel safe and supported. And yeah, so, and I think that's everything that we're trying to do in our maternity and neonatal system across West Yorkshire and Harrogate. So yeah, so that video was really powerful. And so just to give you an overview on the work that we're doing in the local maternity and neonatal system. So as an LMNS, we're part of the West Yorkshire ICB, and we provide a direction and support for transformation of maternity services across the system, as well as gaining oversight and assurance of provider service provision. The current focus of our work is structured around the implementation of the 3-year delivery plan for maternity and neonatal services, and it's 4 key themes, which are around listening to and working with women and families with compassion, growing and retaining and supporting our workforce, developing and sustaining a culture of safety learning and support, and the standards and structures that underpin safer, more personalised and more equitable care. So addressing health inequalities and ensuring that care is personalised and listening to women is threaded throughout that plan, and it's threaded throughout everything that we do within the LMNS. We have multiple working groups addressing specifics within each of those themes. And all our provider services have implemented the Saving Babies' Lives Care Bundle version 3, which is a key driver in helping to reduce neonatal mortality and morbidity, and they've all got really high levels of compliance with that. As an LMNS and ICB, we continue to monitor that compliance with those and have regular meetings with the Trust to assure that all the providers met the requirements from the Maternity Incentive Scheme Year 5 and are working towards the requirements of Year 6, which is another safety strategy to help ensure that our maternities are as safe as they can be. We gain oversight and assurance through various metrics, including clinical outcome data, workforce data, patient and staff services. Staff surveys. We have a health inequalities dashboard, and we use that to identify targeted areas of work for those most in need. The perinatal quality surveillance model is embedded across the system, and this ensures oversight and assurance of maternity services to trust boards, to our LMNS board and to our ICB system quality group, as well as regionally. And we ensure that feedback from our local maternity and neonatal voices partnership is absolutely embedded throughout everything we do within all of our provider services and places and within our LMNS core activities. Our MMVP leads are core members of key working groups within the LMNS and have an open and supportive relationships with all our maternity and neonatal teams. And in recognition of the significant work still required to transform maternity and neonatal services, the LMNS core team is currently being restructured and increased. We've pointed to some new roles, and we're looking at being able to have a greater impact across the system as our team expands. Just on some of the data that that's on the paper, really. So we utilise our Embrace data for the main source of our data, because that's the gold standard. However, it does have a bit of a time lag on that data. It's at least a year behind before we get it. We do look at local data to provide early warnings of issues, and we respond accordingly to those. We've done some deep dives of stillbirths and done some thematic reviews, and we're just undertaking a deep dive of neonatal death data at the moment, and that's going to be presented at our LMNS board at the end of next month. There are some limitations with the Embrace data that we get when we get to West Yorkshire level, and we've asked for some modifications to that. We've written to the Embrace team to ask if they can modify that, and we're just waiting for to find out if that will happen, and that may give us a clearer picture of the actual West Yorkshire position. So some of our trusts have higher rates than others, and that's in relation to the way that they function as a trust. We have a large tertiary centre within our footprint, and they have some additional work has been going on there and significant deep dives of their data. And they do, in the situation of Leeds, they're classed as like one of the super centres, and the link with other large centres across the country to compare their data, to gain peer review and to gain additional assurance of any quality issues that they have, and to share learning. So I mentioned earlier about the Saving Babies Lives Care Bundle. It is one of the key interventions that our services are implemented to help reduce mortality and morbidity within neonates. And there's 6 key elements to that. They are reducing smoking in pregnancy, and fetal growth surveillance, raising awareness of reduced fetal movements, fetal monitoring labour, optimising preterm birth and management of diabetes. We've made really good progress in all of these domains across the system, and everyone met the minimum requirements that was mandated for the maternity incentive scheme, and they're continuing to embed all of those processes and audit compliance with those. It will take time to realise the impact of these interventions, and most of those interventions have been put in place sort of over the last year, and it will take time to really see an impact. One thing that we have noticed already quite significantly is that our smoking in pregnancy rate has decreased. So the numbers of women that are smoking at booking has decreased, but also the numbers of smokers that quit during pregnancy has decreased, which is positive, and the number of women that are actually smoking at birth has decreased, and that is a really clear modifiable factor. So the levels of deprivation are really high in West Yorkshire and Harrogate footprint, and we have a lot of work ongoing to help reduce our health inequalities. We have our Equity and Equality Plan, which was published in 2022, and we're just in the process of reviewing and updating that. We have delivered on quite a few of those elements, but what we haven't really done robustly is really measured the impact of those, and that's what we're looking at currently. We've just appointed to a Health Inequalities Programme Manager who's going to lead on that work, and we'll hopefully have a new plan published within the next couple of months, showing what we've done already, what still needs to be done, and anything new that we've found that we still need to address. We work with all our providers to help further address the health inequalities, and some recent things that they're looking at is pointing to additional roles to help those that are most deprived, and they're recruiting to health equity lead midwife roles, and also recruiting to roles such as called maternity befriender roles and additional support workers that will work with those women and families who are in greatest need and need that additional support to help ensure that they're getting the really high quality care and encouraged to access maternity services as much as possible. So that's just a very brief overview of the report, and the report was sent out in advance, and if there's any particular elements that I wanted more information on, then I'm open to any questions.
Thank you very much, Debbie. So I will open this up for questions and comments, starting with Fatima.
Good afternoon, everyone. My name's Fatima Khansha, and I'm proud to be the West Yorkshire Inclusivity Champion. Thank you for sharing that report and video, Debbie. It was very moving, and as someone who's had some very challenging births, I could really relate to some of the themes that the voice partners were alluding to. I've got a couple of reflections and then a couple of questions, if I may. So the first one is about the opportunity to learn from the maternity work that you're doing and other services in the health and care partnership. So there's some references to sort of culturally competent services and the importance of advocacy on behalf of individuals. And we know that not everybody has the sharp elbows that can advocate on behalf of themselves, despite the role models that you've got in those videos. So is there an opportunity to amplify that in other areas of inequality? The other bit was just referring to some of the metrics and equity of access that you've referred to. So I'm stealing a bit of the thunder from the EDI agenda that's coming later. But one of the themes that's coming through really powerfully is people's access to services. And we know that the data tells us that there is inherent bias from preconception to post-delivery for women when it comes to the maternity pathway. So is there an opportunity maybe to join up some of the work we're doing in that space to really improve outcomes in the maternity pathway? And then the final reflection is that the importance of the trauma-informed work that we're doing here in West Yorkshire. So as somebody that's had two traumatic births, that stays with you for a really, really long time. How do we support women to overcome that trauma, but more importantly, advocate their lived experience to support the meaningful change that we want to see in the health and care system? And is there a way in which we can do that? I also want to draw colleagues' attention to some of the really great work that the Race Health Observatory is doing on skin pigmentation, because there's some reference to that in the video. And also we'll be talking a little bit about leadership and representation and done a Canary review as well. So there's loads of opportunity to join up, but I thought, the metrics in particular and how we're demonstrating change is a great opportunity for us to link up to the EDI strategy. Thank you.
Thanks. Debbie, do you want to come back on those? There's quite a bit.
Yes, there was quite a bit there. Sorry. So firstly, so you mentioned about the trauma-informed work. Absolutely, that's really something that we want to really embed within our services. We have some trusts that have already developed pathways and developed education for staff around that. Some are only just sort of touching on it, and it all fits within sort of our personalised care work stream. We've currently been looking at what the personalised care bit training is for staff, and it's really quite varied across our providers. So we're looking at what does a good look like, what does a gold standard look like, and we've been linking with the public health team to look at what does a trauma-informed workforce look like and what do we need to do to move that forward. So it's absolutely on our radar and on our agenda to move that forward. It mentioned about equity of access. Yes, that is something that that is concerning, and that we have, when we've done sort of our thematic reviews, and some of the things that comes out is that sometimes women are delaying attending maternity services, and we don't always know the reasons for that, but we do wonder if there's an element there, those women that are more deprived. We do know that women make choices based on their own ability. There may be a choice between a bus fare and feeding the children. It shouldn't be that way, but we absolutely know it is. So we this is absolutely, again, part of our work streams to try and improve that. And these new roles that some of the trusts have pointed to will hopefully develop that. And as I say, with some of the work that we're actually doing, our new Health and Equalities Programme Manager, just in week 3, but has already started to map out some of the work that's going on, because we know there's lots of work going on, but what I'm not clear of at the moment is what's going really well, what do we need to copy everywhere else, and where exactly the gaps are. We talk about them, but I don't feel that we've really nailed it at the moment. So that's sort of the plan. And then the last thing you'd mentioned was about, I don't know, written down culturally competent services, and we were talking in relation to staff around that. Is that what you meant? Sorry.
So ensuring that the services we deliver recognise the different nuances of different cultures in West Yorkshire.
Yeah, and that's something, again, that's within our workforce strategies, about looking at, we're encouraging that. And we've just had some conversations the last couple of weeks actually about the offer of culturally competent training. So there have been some of our teams have had some additional training, and we're looking at sort of a train the trainer model as well around that. So.
Thank you. Beverly, come to you next.
Good afternoon, everyone. My name is Beverly Geary. I'm Director of Nursing for West Yorkshire ICB. I'm also the Senior Responsible Officer and Chair of the local Midwifery and Neonatal System Board. I think it would be remiss of me not just to add a few comments, if that's okay, Councillor Swift. So, in West Yorkshire, we have around 25,000 births a year. The scrutiny on maternity services and the safety of them has never, ever been greater. And I've worked in the NHS for a long time. There are nationally prescribed quality improvement initiatives that we are required at organisational, system, regional and national level to report upon. And we have really high levels of compliance, as Debbie mentioned. The context in which we're operating is we've got significant increased choice for women, which is fantastic, but sometimes that equates to really high rates of elective. I'm going to say LSCS, lower segment cesarean sections. So really high rates of cesarean sections. In some organisations, up to 50%, 45 to 50% of women are electing to have sections. There have been significant retention issues in various parts of the country. We weren't, we were similarly in West Yorkshire, we had some significant retention issues that the LNMS worked collectively together to address. And we've had some really positive impact as a result of that. And there's also really high attrition rates in student midwives. And again, in West Yorkshire, we're working to address that. The regulatory scrutiny has never, ever been higher, and it is increasing. However, I would ask you to look at the detail. I'm sure you all have, but I would ask you to look at the detail in that report, because there's some extremely positive things that we're doing to be not just around advocacy, but about safety, reduction of neonatal death rates, and some real scrutiny around some of the patient harm incidents. Some of the work that we're doing with our Maternity Voices partnership is excellent. They're representative now of our local populations, and we've recently increased these in number across, particularly in Bradford and Airedale. But we've also got a Maternity Voices partnership advocate at system level that's working really closely with families. And finally, I'm going to apologise in advance for saying this, Councillor Swift, but I want to recognise the work of Debbie and the LNMS team, because until recently they've been really tiny in number, i.e. 3 people. And now we've got the opportunity to recruit into these really, complex roles and to focus on work on the inequalities, etc. I think they're going to go from strength to strength. So thank you for that.
Thank you. Anne.
Hopefully, sorry, it's taken me a bit longer. Yeah, good afternoon, everyone. I'm Anne Carroll, and I chair the Wakefield Health and Social Care Partnership Committee. And again, a comment, thank you very much for the video. I thought it was excellent. And I've had personal experience. Well, in fact, it's my daughter-in-law's experienced, recently had a baby, and I was amazed at the work and effort that the midwifery service put in to ensure that she had a good experience and that her choices were listened to at every opportunity. So that's a positive experience. What I was going to come on to, I think really, obviously, I'm out of date to an extent on this, but obviously women and their choices culturally are changing dramatically, and where they get all their information and knowledge from is changing dramatically with social media. Are you finding that the choices that women make, and I was interested that 40 to 50% in some areas are choosing a section, that things like the standalone midwifery-led unit, and you can see why I'm probably going to come on to this question, are becoming not viable because the fewer number of young women now are choosing to deliver in standalone midwifery-led units. So that was one question. And the second was postnatal support for vulnerable women, particularly from deprived areas, and also for those who've had a trauma at birth. It does seem that there may be a gap there, again, due to staffing levels, I would think, and they're perhaps not supported as well as they might have been in the past. So those are my comments and questions.
Thank you, Debbie. Do you want to come back on that?
Yeah. So just first of all, on the support element, the postnatal support and trauma support. So I think there is a little bit of a gap in the postnatal support. I think that generally a lot of women do get the support they need, but there are those women that require extra support and would particularly benefit from more in that postnatal period. And it's something we've just started looking at. It's not been something that we've had the opportunity to look at previously, and we've just about 2 weeks ago now, we held our first postnatal steering group to start looking at the gap with postnatal care. So that's hopefully something we'll start to move on. As I said, there is provision there. It's not that there's not anything there, but so that is an action for us. And that trauma support as well. So we have there are services in all of our providers for a debriefing service and additional support for those that have had birth trauma. We also have a maternity and neonatal independent senior advocate that works for us, and it will provide care for women and families that have had particularly defined adverse events. That's an NHSE pilot that we're part of. It is part of that role. And one of the things that we're doing as part of that is looking at the information that women and families get following an adverse event, and also looking at what that debrief provision is to check that we've got it right, and is it equitable, and what's there. So it's things that we're working on. I say a lot of things we seem to be working on, but yeah, acknowledge that. Then you'd mentioned about choices, and about women perhaps not choosing the midwifery-led units at the moment. I couldn't say exactly what the reasons for that is. We do see that there's more and more women now that I do have risk factors identified during their pregnancies, and that's for various reasons. And I know that was sort of mentioned in the Darcy report about that we have more women with obesity and more women that are giving birth later, as well as other medical problems that then increases there. Therefore, not be identified as ideal candidates to birth in the midwifery-led unit setting, so that is part of it. And I think part of it, as we mentioned, as Beverly mentioned, about that in media scrutiny, and that maternity has always been regarded not necessarily in the highest regard. I think that changes women's opinion as well. They don't always feel as safe and supported, so they make what feels a safer choice by picking hospital births sometimes. And I think we've not always had them available, so we've not perhaps promoted them either and explained to women as co-ladies what benefit there might be to them. So I hope that answers your question.
Yes, thank you for that. Thank you for that.
Thank you. So I've got Claire next.
Thank you. I thought that video was absolutely superb, and I have to say I felt a lump in my throat towards the end of that. One of the things I think we need to acknowledge, because we must continue to improve the services that we provide to our population, but one of the things that I think we do need to be mindful of is the level of scrutiny our midwives are under currently, and the impact that's actually having on them in their personal lives and their professional lives. And what I would hate is for them to get to a point where they are fearful of making of decisions that they're making because they're feeling second guessed all the time. So I think we need to, as a healthcare, as a care partnership, we'll have to pay some really close attention to feedback that we get from our teams as part of the staff surveys. Because what we can't afford to do is lose these very dedicated and talented individuals from our services, and I think we also have a duty to support them to be the best that they can possibly be. It is such a difficult environment for these colleagues at the moment, and their experience isn't always great either. And we need to make sure that we are continuing to improve those access to those services. And also improving the experience of our teams at work.
Thank you, Claire. Can I come to Rob next?
Yeah, thank you. This is a really important topic, and one which is and has been contentious. So it's good that we're discussing it today, I think. So I'd sort of three comments and questions, really. The first one was just to recognise that elsewhere in our conversations, we've talked about perinatal mental health and the access to perinatal mental health services, and the fact that we've got good access in terms of timeliness. There's no waiting for the perinatal mental health service. The national calculations of how many women should be accessing the perinatal mental health services are higher than the numbers accessing. So just wanted to see, Debbie, if there's any further opportunities for us to ensure that we're signposting or creating easy access for people who are underrepresented in the perinatal mental health service. That was the first one. The second was, thank you for pointing out the positive progress in the report. And Beverly also highlighted some of the positives. It's really good to see, and alongside things like the publication of the NHS England and ICB review into the neonatal services in Bradford, which said they were good, safe, high quality, and had good practice to share, we can see that there's really great stuff that we should be talking about to support our midwives and their teams. So I think that was the second point. But the third was that this was an area I think we're making strong progress on prior to COVID. And then the numbers started to go backwards a bit during COVID, and we're now improving again. We still do, though. So two elements, two questions really get linked to that. One, are we on track, do we believe, to make the improvements that we wanted to? And secondly, particularly in relation to ethnicity and deprivation, where para 19 is quite startling around the rates of stillbirth linked to ethnicity being, let me just make sure I've got this right. Sorry, it's maternal mortality, isn't it? So 4 times more likely for Black women, twice as likely for Asian women, and twice as likely for women living in the most deprived geographies, with similar representation in West Yorkshire. So those were England data. So are we making progress overall, and are we scheduled to make more progress in that space, and what help do you need to make sure that we do?
Thank you. Debbie, do you want to come back on those before I bring?
Yes, so first of all, in relation to access to perinatal and maternal mental health services, so we are starting to collect data on that. We do know that certain populations are least likely to have a referral to those, and that's some of the work that it's not particularly by my team directly, it's more with the mental health team, but we absolutely link with those, and we do think there are some cultural elements to that with regard to mental health that we need to look at particular work streams for how we address that. I haven't got any particular answer at the moment, but we do know it's a gap, and it's something that we need to work on to ensure we're getting all the information to maternal mental health services. The new maternal mental health service that we have, the PATH service that we set up particularly for women with birth trauma, that was first set up, had a soft launch in July this year, and it's had its formal launch just this month. So that's quite new, and I think the promotion of that and the uptake of that will be quite a tell of how we're reaching all the women that need this service, and that's ongoing work and data collection. And then you'd asked about, are we on track to meet the ambition? So if we're talking about meeting the ambitions overall as the Have It campaign, no, we're not on track at the moment. We have made some improvements, but it does not look like we will meet the 2025 ambition, bearing in mind that we're already middle of October of 2024. We're not on our own with that. We're not the only ICB or alumnus footprint that is saying that. That doesn't make it okay, but we don't feel that we're doing anything particularly worse in other areas. And I do think that health inequalities gap is there quite significantly. And whilst there's work being done, at the moment, I don't think it's been at pace enough to address the gap that is required, and that's what we need to pick up now. So really, the ask of you, really, I've had some comments in the chat there about linking and support and things, and absolutely taking people on that from that. Now that we've got our alumnus team much more established, and we can identify what we need to do, and then whatever support we need, we will take that to try and start to deliver.
Thank you. Got 2 more people indicated. I'll take those and then come back to you to sum up, Debbie, if that's okay. So Andrew first.
So Andy Withers, interim chair at Airedale. Just picking up on the health inequalities point that was earlier raised, one of the most impactful interventions is preconceptual care and early booking and access into antenatal care. And there wasn't a lot in the paper about that. And I just wondered the role of the partnership and the LMNS in improving that, and what we will be doing in place and partnerships to improve early access to maternity care.
Yeah, so we're as an LMNS, we're not actively doing much in preconceptual care at the moment. I acknowledge that is something that can help and address. It's not part of our current key work streams. As I said in the report, that our key work streams are around that 3-year delivery plan, which isn't really about that element, but absolutely acknowledge that that's a gap. I am aware of one of our places has been starting to look at this gap and say, is there something else we can do? But it's literally just some early conversations that I've had about that preconceptual care. It would need quite a lot of scoping in the first instance to identify what exactly that looks like and what the work would need to do.
Thank you. Brendan.
Thank you, Chair. And Debbie, thank you for that presentation. It was great to hear about the work that you're doing. And my comments are probably in support of what you've described. I think we could respond to this because of the regulatory framework that we're operating in, and indeed because some of the media scrutiny. But I'd be really keen to assist and support the LMS in that continual improvement journey. That's why you're doing this. This absolutely has to be about a better experience for women and their birthing experience. But there's also, and Paul, you've kindly put something in the chat. I do think we should seize the opportunity that we have in front of us as the opportunity to build a health service fit for the future. Surely this is where it starts. If we start with, there's a cradle to grave opportunity, but if we start with the cradle element of this, as a West Yorkshire community of leaders, how do we encourage not only our colleagues working in the breadth of this field, but also our women who have either experienced our services or are about to experience our services to actually take an active part in that engagement session? That's how we're truly going to improve what we offer. So I just think there's perhaps an ask for all of us in how we encourage our communities to be involved in that true consultation piece.
Thanks very much. If I could ask, I think this may be as much a question for Rob as for Debbie, perhaps. I think picks up what I just saw, Rob, in the chat. This report and this discussion felt very focused on clinical services, and I understand why, and we're reminded very powerfully by some of the contributions in this discussion about just how much focus there is on maternity, and quite rightly. I just wonder, in terms of the partnership's ambition as a whole, is there something perhaps separate we need to talk about in terms of the kind of wider public health prevention role in this, or are those discussions, does that happen somewhere and I'm just not familiar enough with all of the geography of where this takes place?
Certainly something which is linked, and remember that one of our maxims is that we need to connect the system to more of itself, and we'll be doing a bit of that, haven't we, in this conversation around things like perinatal mental health and the work that the team there are doing. Certainly something that Beverly and James Thomas, the medical director, can pick up with support from Debbie and the Improving Population Health team. Yeah, I think there's more that we can do, Tim, but although we have focused on the medical elements to an extent, I think what we heard in the video, what we heard from Debbie, what we heard from Claire and others is it's the relationship, softer side, cultural competence, safety, trust elements that are incredibly important here. And I think that's one of the big messages too. The public got to have confidence that the services are good, and women and families have got to have confidence that they'll be listened to and heard.
Thank you. Yeah. Tracy.
Yeah, just backing up what Rob has just said, and also Fatima and others, that it definitely isn't right that women of colour are 4 times more likely to die in childbirth. Just one thing that maybe it's in the data, and maybe I missed it, regarding the stillbirths. Have we got ethnicity data on stillbirths? Because the numbers are definitely going in the right direction, so that's a good news story. But it would be interesting to see, and apologies if I have missed it, if you just pop it in the chat, that would be great. If there's been a bit of an analysis of stillbirths, because that would also give us the data around mothers and babies' mortality.
Thank you. Debbie, can you help us out?
Yeah, so that it has been done, and I think what we found is that the West Yorkshire picture for stillbirth is similar to the national picture, as in women from Black and Asian backgrounds are more likely to have experience stillbirth and other perinatal losses. So we are similar. We know worse and know better from that point of view.
Sorry, Debbie. Sorry, it was a bit more nuanced, I suppose. It's that the numbers are going in the right direction.
Yeah.
So what are the interventions that are happening to push those numbers down? but are they going down in just one group of women and their families?
From what I recall of the data, it's going down across the board. But I would have to check that and to confirm. And I think one of the key elements that's happening is the Saving Babies Lives Care Bundle has been a pivotal factor in that. Whilst it's this current iteration only came out last year, we've been working on that for a few years, and some of the interventions in that, including optimising preterm birth, because women who have a preterm baby, there's really high mortality and morbidity rates for babies that are born preterm. Raising awareness of reduced fetal movements, having reduced fetal movements is a key element. Management of babies with that are small, and smoking as well, helping reduce smoking rates. All those key interventions are really quite significant in helping to improve that mortality and morbidity. So that seems to be the key driver for that. But I say I will have to check on that data. It has gone down in proportionately. I haven't checked it recently, so I couldn't say.
Thank you very much. So can I conclude that item then by saying thank you very much, Debbie, for that report and presentation, and pass on our thanks to your colleagues for the work this represents, and endorse. It's clear as a board we appreciate the challenges of this area and support the actions and the measures that you're taking. So thank you. At this point, we're going to take a brief 10-minute comfort break. So we'll resume again just after past. We'll turn off the live stream for this period and then restart it as people come back. Thank you.